Dr. Kaushik?
So let me introduce Dr. Kaushik. Dr.
Kaushik,
Kaushik
yeah.
is in regenerative medicine. He has done doctorate in regenerative medicine, as well as he is an expert in stem cell therapies, and he is a speaker for so many universities in regenerative medicine all over India, all over the world. So please, Kaushik sir, thank you for coming and joining us. Please
Hi.
continue.
Yeah, thank you, Azhar. Thank you so much. And I'm just trying to figure out how to start this video. Okay, now I've got it. Hi, everyone.
Okay.
Good
Yes.
evening.
Hello, sir. Good evening.
All good, sir. How are you?
Yeah, fine, everything. And go ahead. So, future is
Yeah,
the regenerative medicine.
yeah. And we are very excited to be here. And thank you so much for giving this opportunity. Let me open my. Okay, so Azhar, you have to enable my screen sharing. Hello, Azhar?
Yeah, share is there, no, sir, in the green. Green is there in the bit in the center of the
No,
screen.
it is saying host. Yeah, it says host disabled participant screen sharing.
Okay, I will just share.
So somebody has to enable this.
Yeah, sir.
Azhar, you stop, you enable
Yeah,
your steering.
yeah. I have started, sir. I have enabled it. Please start it.
Yeah.
Now you can
Okay,
share. Yeah.
yeah,
No,
I think I'll be able to share it now.
10 minutes.
Is it coming?
Yes, sir. Yes, sir. It is coming, sir. Please.
Okay, so let me. So yeah, I have been into regenerative medicine for quite some time. The history is about 15 to 20 years long now, and we have bootstrapped this company, and then recently we have done some fundraising also. But that we are talking about is Medicines Therapeutics. Today we are going to talk about solutions that are for stress urinary incontinence. And so a little bit about us and a little bit about me and our company, and then I'll go ahead. So
Kaushik, sir, your voice is not clear. The voice improve, increase your voice. Volume is
yeah,
increase.
okay, 1 minute.
Right. Right.
Mm, is it audible now? Hello?
Yes, sir. Yes, sir. It is audible right now.
Yeah. So actually, this company, its name is Dipont Biointelligence. It's a regenerative medicine company which develops therapeutics. We are focusing on, it's an R&D company which focuses on developing point-of-care biologics, stem cells, cellular therapeutics, biomaterials, and also for precision medicine, some molecular diagnostics, which uses genetics and LC-MS/MS like tools. And we also offer education and training program, which is an online and hybrid course through our institute called DuPont Institute of Regenerative Medicine. Coming to my background, I am a PhD in immunology, molecular immunology, and a postdoc from Vanderbilt University Medical Center in the US. I also had DBT's overseas fellowship from I went to a bilateral exchange fellowship to the Ottawa General Hospital, Canada, then Indian National Science Academy fellowship with the Czech Science Foundation, and then a short, what you call that, a management program from the IIM, and then I have a fellowship in clinical regenerative medicine. So I have about 25 years of experience in R&D, biotech, biologics, and development of all these biologics, cellular and molecular immunology and stem cells, etc. We have been awarded several research grants from the Ministry of Health and Family Welfare, Government of India, the Department of Biotechnology, and US-based fellowships, etc. Then we have developed a lot of what you might say, a lot of preventive healthcare products and testing kits, including very challenging kits like liquid biopsy tests and also biological age determination tests like the telomere length assays. And So overall, I have published more than 100 international peer-reviewed papers, books, chapters, etc. So that's the credibility. We are totally R&D focused company. Our mission is to develop faster, better, and cheaper treatments for chronic and degenerative medical conditions, and we are doing it in all kinds of conditions like spinal cord injuries, including skin, liver cirrhosis, uh, then cancer and heart diseases, central nervous system related degenerative diseases like Parkinson's, Alzheimer's, and also bone and diabetic foot ulcers, type 1 and type 2 diabetes, etc., etc. For last 15 years, we have developed a lot of these treatment protocols with different hospitals and clinicians using different R&D protocols. And our vision is to transform treatments to cure, because every other pharma company is offering a treatment, but very few actually wants a cure out of the disease. So we are trying to position ourselves in that way. So this is something that we have developed so far, and like we have about 20. So we have our own CGMP manufacturing and R&D, and we have developed more than at this point in time, we have got licenses for more than 7, 8 point of care biologics, which includes nanofat for anti-aging or reconstructive surgeries or aesthetics, then bone marrow mononuclear cell concentrate products and devices for orthopedics, neurology, or oncology, and even platelet-rich fibrin matrix for periodontology or wounds, ulcers, etc. And then we also have PRP. And then PRP itself is a vast area where we have developed 2, 3 variants of PRP, like the Leakage PRP or the fibrin poor PRP and stuff like that. So, and on the cellular therapeutic side, which is on this side, on the right hand side of the screen, we are working on many peptides which are for treatment of hair loss and skin regeneration. Also CD34 cells for bone marrow and other blood related diseases and disorders. Then some mesenchymal stem cells for graft versus host disease and solid organ transplant kind of setups. And also we are also working on some mesenchymal stem cells for arthritis, rheumatoid arthritis, and osteoarthritis as well. We are working on right now. We are working heavily on the CIK cell therapies for cancer, like solid tumors. So CIK means cytokine-induced killer cell therapies, and we are developing insulin-producing cells as a transdifferentiated population from mesenchymal stem cells for transplants. And we have been doing a lot of type 1 diabetes patients with this, with very good results. I will skip this slide. This is a very crowded one which has the USPs, but definitely we want to be faster, better, and cheaper than anybody else in the market. And we are going to be perhaps made in India and very cost effective. And those are our USPs. And everything is developed in house, so we have no foreign dependence. And we have more than 5 Indian patents at this point in time, 6 in pipeline, 4 international patents are out of that, 2 are granted, some more are in pipeline, and some clinical publications are there, about 15 clinical publications with related to different disease conditions. Besides that, I mean, coming back to our topic today, uh, these are the products. This slide will is a list of the products that we are focused on, or you would have for treating stress urinary incontinence. And so the 5 major product out of which can be easily translatable to clinical setups. One is like, say, LPRP, which is a Leakage PRP, and it should have a 15x concentration. I'll come to that. I'll come to the detail, the more description about each of these products. Then we have these exosomes with the biopotentiated gel, and then Meresis MS6, which is actually the name of the API. It's actually a mesenchymal stem cell population which with very high anti-inflammatory property, and which overexpresses exosomes which are derived from urine derived stem cells. And then Meris's muscle cell transplants, which is again an autologous procedure, patient specific. And based on the ease of operations, you can say that the easiest is say the number 1, and the hardest will be the number 5. So ease of operation wise, it is like hello, hello,
No,
hello.
sir, you can continue. There is some, no
Hello.
problem. Kaushik ji, you can
Okay,
continue.
okay, 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 okay. So, 1 minute. Uh, where is that? Somehow I think I've come out of it, or so sorry for this. So now, so that's the ease of this thing. Ease of operations wise, this is the distribution from number 1 to number 5. Now, coming to so yeah, what we did. So there is very less data right now about the clinical significance of each of these products. So we used a artificial intelligence based prediction system for using all the publications that we have in the PubMed or other medical this thing, websites. And then this prediction has we have used this algorithm. Intervention will be best, which protocol will be best for what kind of stages of stress induced urinary incontinence. So we have the AI as per AI prediction based on the data, available data. The LPRP is the easiest thing to use, and also it can be used for mild SUI. In moderate SUI, the Mesis exosomes or exosomes with biopotentiated gel, that would be the best option. And exosomes from urine derived stem cells, those two are the best options for moderate SUIs. For severe SUIs, then again mesenchymal stem cells and or the muscle cell transplants. This is the distribution based on severe or mild, moderate, or severe SUS. So depending on the complexity, you can choose one of the products. So coming to LPRP, which is the most easily doable, or easier to obtain and the most cheapest option that is there in the market at this point in time. So the mechanism is platelet-rich plasma, but this LPRP is a product which has leukorich. It is leukorich PRP, so that means it has mononuclear cells and it has the leukocytes in that. So it gives you the growth factors of the platelets plus the stem cells, stem cell growth factors, and we have an activator with it which gives you extra release of growth factors, and that makes it very potent. And our system gives you 15x concentration or 15x strengths of growth factors. And how it works is it promotes, so it has various growth factors like PDGF, epidermal growth factor, fibroblast growth factor, TGF beta, IGF, VEGF, etc. And as everyone, most of you know, that it helps in angiogenesis, collagen formation, and cell proliferation, and overall it is helps in tissue regeneration. So now this product can be used in like in this, if you see on the right hand side, this is how our LPRP looks like after preparation. The yellow part of this is the this thing, it's a mix of the top part will be the platelet poor plasma, and bottom about 1.5 ml will be the platelet rich plasma, and you see a very good separation of all the hematocrit. So this is a very pure form of the PRP, and it will give you about 15x concentrations and metabolically active platelets, unless you put the activator, we give an activator. and you can activate the platelet RP, and then you can inject it. So usually there are ways of doing it. Different clinicians use different ways of injecting, but the usual dosages are like about 1.5 to 2 ml in per shot kind of a thing. And you can use it in the I mean, that's how you use it for regenerating the urethral support structures or muscles. And this is again, we recommend it for mild to moderate this thing, SUI. Then exosomes. Now, exosomes, what are exosomes? Exosomes are basically extracellular vesicles. They deliver bioactive molecules like miRNA, proteins, cytokines, and even there will be other peptides and nucleotides in them. They are basically waste material of a cell, which is secreted by the cells in a culture system. In a culture, when you culture, when you do large scale culture of mesenchymal stem cells, or any, even the muscle cells, or any cell, the cells throw all these metabolic wastes in the culture media, and we actually harvest this waste, because these wastes are loaded with so much regenerative molecules. So you harvest them, concentrate them, and then you can inject them. So how do we make a biopotentiated gel out of this? Like, we mix the exosomes and we take the patient's blood and we make a platelet-rich fibrin. So this fibrin also, it is like an injectable fibrin. So we call it as IPRFM, injectable platelet-rich fibrin matrix. And it is done, unlike PRP, it is done with a slow spin, and it is also a one step 7 minutes protocol, and it's very user friendly, and you can get what is known as an exosome and biopotentiated gel together, and then you can use it again. And this picture here is our exosome vials, and this is what we produce anyway for different indications, right from in regeneration of the hair, skin, or diabetic foot ulcers, or even some soft tissue injuries. So basically we are using two different products together, exosomes and the PRFM together, to make this biopotentiated gel. Then comes the exosomes from urine derived stem cells. So what is basically done here is, you can harvest the you can take this urine from the patient, and then from the urine actually has a lot of bladder cells in that, and you can actually isolate the stem cells also from this urine. So we isolate the stem cells, grow them, and after growing, you have to kind of culture modify and make them in larger numbers, because you get very small numbers, and then you have to mix these cells with the exosomes, and then you can again inject it. And this is as per our APIs, artificial intelligence algorithms, this with all the published literature data and all, it looks like this is good for moderate to severe SUI conditions. Then we go to the fifth and the, let me see. Yeah. Okay, sorry. I think I missed this one. Mesenchymal stem cells. So yeah, so this mesenchymal stem cells can be used as well. So what we do is, we basically take umbilical cord tissue. From there we take out, or umbilical cord blood also can be taken from newborn babies during the birth. And you harvest this and take out the stem cells using a density gradient centrifugation method. And we have to culture expand them in a class 10,000, class 1000 or a class 100 facility, CGMP, under CGMP norms. And we have then we can actually start with few cells and grow up to millions of cells. And once the cells are ready, we can inject them. And also this is getting used for severe SUI cases, and this is being recommended for that. And it's a little expensive because it involves a lot of cell culture. So So these are some diagrams where we have shown like how cells can be expanded, and then it has to be characterized, and then it has to be formulated, and after the formulations are done, it will be transferred to your clinic. And once it comes to your clinic, you can yeah, you can do the procedure. So I think this is the last one. So this is the muscle cell transplants. What basically is done is you have to take a muscle biopsy and then culture expand them. You start with maybe a few hundred cells, and then you grow them to millions, and then formulate them in an injectable format, and then inject it. But then what the literature suggests is you can also combine this with electromagnetic stimulation. So this is also again recommended for severe SUI, and uh, the clinical relevance for this is like it is highly effective for severe cases with sphincter insufficiency, but requires a little invasive procedure. Uh, Recovery may take a little longer compared to exosome therapies, because anyway we are choosing very difficult to treat conditions in this. So uh, that's all. And then these are the different products which are already launched by us, which are already CDSU approved. Uh, so thank you, and I can share this slide deck with anyone who is interested in working with us or collaborating with us further. Thank you.
Thank you, sir. Thank you for your great slide. So, Shankar sir, can we continue with the main
No,
agenda?
before I continue, I want to ask Dr. Kaushik, very, very excellent demonstration. Still, all the urologists, gynecologists across the road, they are confusion. But what you was clearly explained, what are the new regenerative things to the managing the SUI, stress urinary incontinence. So I have some doubt, Dr.
Please.
Kaushik ji.
Yeah, please.
For example, we were concentrating mild to moderate.
Mm.
So we have been working for since 4 years in PRP, only PRP for intrasphincteric and periurethral and suburethral.
Mhm.
So we are getting the result like 50, 70 in between. But what you exactly should PRP, LPRP?
I think,
One,
instead of doing a pure PRP, which is platelet-rich plasma, there are in a PRP, sir. I would like to draw your attention to two things.
mm,
One is in PRP, you should not generalize PRP. So PRP has
okay,
a dosage concept as well, so which very
okay.
few people know. So you have to have the right number of platelets. Like I will give you I'm diverting a little bit in this discussion. Our experience when we started PRP, and we were injecting PRP in the hair, in the skin, in the knees, in the diabetic foot ulcers,
Mm,
everywhere, same PRP.
mm,
And certain things used to work, certain it didn't work. Then we started playing with the concentrations per injection, and then
okay,
we found out the dosage. Like, say, for example, in orthopedics, if you are
okay.
doing 5x PRP, it is good
Mm,
for soft tissue injuries, but it is not good for
okay,
cartilage regeneration. It doesn't give any regeneration.
okay.
So we started finding out that a 15x concentration is minimum required for having a cartilage regeneration, because before that doctors used to say that cartilage regeneration is impossible. So but we have shown in avian as well as arthritis patients, and we have 10 years of data now in those patients, that it is a stable cartilage regeneration, and they are jogging. These guys are jogging now. So what I am trying to say is, the dosage concept is there. How much you are injecting
Mm,
every time, what concentration
yeah.
is getting in that. And similarly for mesenchymal stem cell also, a minimum of 2 to 5 million cells per kg body weight has to be injected. So there is a dosage now in every cell therapy or cellular biologic.
Mm,
Now you are saying about the PRP. Now
mm,
LPRP is something which has it's a leukorich PRP. It's a different product than simple PRP. Simple
okay.
PRP is like pure PRP. There is only
Right.
platelets and plasma. But
Okay.
this one is a mix of mononuclear cells and the PRP. So we call it the supercell PRP. Why
No, no.
supercell?
With the preparation process, you have a special kits
Hmm.
for this, and what
Yeah.
ingredient
Yes.
and anticoagulant you use. What is the spinning concentration?
Yeah. So this our is a one step separation using a thixotrophic gel. This
Okay.
thixotrophic gel is it has a specific gravity which is
Okay.
similar to the mononuclear cell specific gravity. So what happens is
Okay.
all the other cell components, like whether it is the RBCs and other things, they all go through the gel and it goes down. But only the, if you look at it, let me see if I can show you. Yeah, if you look at this picture, so you'll see
Yes.
that
Yes.
there is a white component here. Can you see my arrow?
Right.
Yeah.
Yeah. Yeah. Understand. White component. Yeah. Yeah.
Yeah, this is the gel, sir.
Mm,
It's a thixotrophic
mm,
gel, and we have the technology to
mm.
manipulate this thixotrophic gel density. So the
Okay.
viscosity and density we can play. So what happens is we select like which component of the blood needs to be separated out. So suppose we
Okay.
want only platelet-rich plasma without any
Right.
mononuclear cells. So we'll take the specific gravity of the gel will be same as the platelets or a little higher than the platelets. So what happens is after spinning, everything will go below the gel, only the platelets will remain up.
Right. Right.
Okay, now when we want mononuclear cells and the
Mm.
platelets together, our thixotrophic gel separation will be like the specific gravity of the gel will be a little higher than the
Okay.
mononuclear cells, so that it will cut off only the mononuclear cells and the platelet-rich plasma. So then you
Right.
in your harvest you are getting the mononuclear cells as well as the platelet-rich plasma. So this is a 7 minutes one-stop or single spin technology, and you do not have to rotate again and again. I mean, spin again and again, and it is for dummies.
Thank you.
Yeah.
Thank you. Thank you, Kaushik ji. And I have one last doubt or last question.
Mhm.
Sir, cell therapy, like you are telling, like a muscle cells, we are taking from the muscle cell and culture it and transplant to the affected site.
Right, sir.
You have any, you have experience in India they are doing, or you are have
Actually,
done,
see,
you are,
sir, we have done a lot of these kind of things. We have done a lot for muscular dystrophy patients, as well as we
okay,
have done a lot for other degenerative conditions,
right, right.
skeletal-muscular things. So technology-wise, we have it, but
Yes, yes,
not nobody has tried in India. Nobody
yes,
has
yes.
tried it in stress urinary incontinence. I
Okay.
mean, to my knowledge, to my knowledge,
Yes.
I do not know if somebody has done it, but I don't think. But what I am trying to
Mm,
impress upon all of you here is, here we have
mm,
a lab or we have a
yes.
research team here which can give you this support, which have the
Okay.
capabilities to do all of these, and we
Okay.
can collaborate and we can develop all
Okay.
of these into treatment modalities. So because we have the
I think there is a Movan company in Switzerland. They are doing this type of cell therapies.
Mhm.
Then I can advise you collaborate with those company, and we can start in India in future.
Sir, this is a good idea, but what I'm trying to tell you is like we have been doing it for last 10 years. Muscle cell culture is nothing for us. As I've
Right,
been
right.
telling you,
Okay.
yeah, muscle cell
You are.
culture, making neuronal cells, even
Oh
dopamine
my gosh.
producing cells, even insulin producing cells. We are champions in all of this. But
Yes. Okay.
the
Great.
problem with India is India got the regulations only 2019.
Do you know ethical committee that requires in permission, or a DGCS, like a
Yeah.
drugs and this
So
request
yes, yeah.
stem
So
cells?
for doing smaller studies, you can just
Mm.
take an hospital ethics committee approval or something like that. But if you
Okay.
want to do a larger
Clinical.
product development, then you need DCJ.
Right.
Otherwise, you do not need DCJ. So
Okay.
or you do not need the CDSCO. CDSCO comes in the picture only when it is a product development. If you are doing a
Okay.
treatment, it is a service.
Right.
So you can do it with the institutional ethics committee and informed consent.
So thank you, Kaushik. Very, very excellent. I excited to see all these things, new things, and
Sir,
a new
yeah.
era. regenerative medicine. Definitely, a lot of Indian women require this treatment in future.
Yeah.
Thank you for your support and all sharing knowledge.
No, no, I am happy
Okay.
to be in this platform. We'll collaborate and we'll see.
Yeah, sure, sure. Future we'll have a teamwork, multidisciplinary teamwork. Okay,
Yeah,
you
definitely.
can
Thank you.
unmute yourself and you can this one. You can close your slides. He has to close. Also, you can close your slides.
Yeah.
You can close because I want to share my clip. Azhar,
Yeah, sir, it is done, sir.
it is okay.
Yeah, yeah. Now you
And
start
no,
sharing.
no, but you have taken lot of time, lot of discussion, and it is very time. But I have some 200 slides. It takes more time.
Please, please.
Now, you are seeing my slides?
Yeah, sir. Yeah, sir. We can see.
Yeah.
No, can you have slideshow? Okay, Azhar,
Yes, sir. Okay, we can see.
my voice is clear.
Yes, sir. It is clear.
Yeah. Thank you, Azhar and Kaushik. You have given one technology, and the another is regenerative medicine. How to do modern innovative technique for stress urinary incontinence. So let me start with a clinical approach using technology and regenerative things in the future. So now I'm going to explain the stress urinary incontinence. What is a urinary incontinence? Any involuntary loss of urine, it is called urinary incontinence. There is a International Continence Society. They given definition that the complaint of any involuntary leakage of the urine, that is called urinary incontinence. It has maximum 4 types. So one of these stress is more urge and mixed one, overflow, functional, continuous urination. These are the different types of urinary incontinence. Because of basics, I'm going. So the one is urge in urinary incontinence. Urge is what is urge mean is there are the associated with the urgency, unable to stand before till going the bathroom. So causes infection, neurological obstruction, unknown causes. So the urge incontinence have also mixed incontinence. So urge incontinence treatment is lifestyle modification, bladder training, drugs, and modulation, especially posterior tibial nerve modulation, because of detrusor myomectomy sometimes. This is the urge. Okay, this is. But our concentration, our main in the subject is stress urinary incontinence. The stress urinary incontinence, the effect of incontinence is a form of urinary incontinence. When you're laughing, coughing, or sneezing, jumping, suddenly you are sitting and standing, will have a urine leakage because of intra-abdominal pressure. So there is intra-abdominal pressure or intra-urinary bladder pressure is more than the what pressure in the intra-urethra. To urethra. So this is cannot withstand a urethra, then it's called leakage. It's called stress urinary incontinence. Okay, you got it. This is basic definition. If you come the prevalence, the cases of in the society across the globe, 1 in 3 women are suffering from in a urinary incontinence. It's especially in India, it is unspoken problem. They are suffering silent. Silence is suffering. If you see this, so 78% are suffering, and in the stress is 50%, urge is 20%, mix is 30%. Overall, the stress urinary incontinence is a 70%. In all urinary incontinence, stress is 70%. If you see the severity grading, you see the very severe 10%, severe is 26, overall 30%. Mild to moderate is 70%. You try to understand. So mild to moderate, we are now concentrating on mild to moderate cases. Severe cases, okay, you can have a surgical problem. So this is the slide shows 70% of mild to moderate SUI. What we would do is a non-surgical method. We are explaining. This is you have to think about it. So the prevalence of these cases, if you see the Procter Gamble, they are given articles. If you see the baby diaper and adult diapers in the market, top sellings are. If you can answer which is the top selling, you can answer. If you can answer, we'll give a good gift for you. So this is the evidence of the how the severity of the problem in the society. So causes of incontinence, severity, duration, the risk factors. What are the risk factors of old age? Main old age or middle age. There is a aging factor. Next is the pregnancy. Then the surgical factors, vaginal delivery, even cesarean also, obesity, smoking. So these are the risk factors to have a SUI. Coming to the basic anatomy of the urinary bladder, you know the urinary bladder has a female short urethra 4 centimeter. Proximal, it is the responsible for passive continence. It's involuntary. Distal have a skeletal urethra that is called rhabdosphincter. It is involuntary. So we have a urethral attachment. It is from the pubourethral, uretropelvic, esophageal, and the cardinal ligaments. So this is a basic perineal body. It supports the bladder, and we have a to avoid urinary leaks. So there are onset of SUIs, mainly three onset. One is the age is the childbearing. Second is perimenopausal. Third is the loss of older age. So you can see now these three categories of onset of SUIs. The symptoms I already explained. Grading, there is no grading details of the monitoring system. It is, but clinically you have to can see there's a grade 1, grade 2, grade 3. Basically of a stress. So how much? A severe stress, it is grade 1. Moderate stress, grade 2. And the simple stress, if you are leaking, that is grade 3. So these are the things you can divide the grading clinically. So coming to the pathophysiology, I'm just moving forward fast because I want to cover the technology after this treatment. So I'm just moving forward. Don't mind it. So all this causes already we explained. Coming the pathophysiology. Pathology, physiology, what are the pathology role for this stress urinary incontinence? Main pathology is the weakness of the urethra and the bladder. There is a muscle tone is decreased, and the urethral tone will be decreased. So there is a hypermobility of urethra, the intrinsic deficiency of the urethra. So if you see pathophysiology, 80% of urethral hypermobility due to descent the bladder neck proximal urethra. Because of muscle weakness, this proximal is nothing but the bladder neck. Proximal urethra, a smooth muscle is bladder neck. It's descent in the urethra, bladder neck. So this is the main hypermobility of this 80%. Next is the 20% have a middle urethra intrinsic tone deficiency. So if this is the two pathophysiology factor, you can see this. So this is the internal urethra. You can see the smooth develop a smooth muscle, involuntary the action. This is a rhabdosphincter, external muscle. We have a skeletal muscle. So if you see the anatomical factors, so there is a urethra become a aging, weakening, and the tone is decreasing due to the childbirth, other hormonal problem, aging. So these all the factors affect the urethra and perineal body. So the events urethral support also like a facial attachment, ligaments, muscles, smooth muscle, mucosal covering, all this extrinsic, intrinsic, all this anatomical structure become a weak when you develop SUI. Okay, so these are the anatomical structure wise you are doing. If you see this molecular wise, ligament, urethra sphincter, there is a collagen fiber decreasing, broken collagen fiber, elastin fiber broken. These are the molecular things which happen the weakness of connective tissue or degenerative tissue of sphincter muscles. bladder muscles. All this, if you go this, the whatever the collagen fiber or elastin fiber damage, thus reason they are cause of the SUI. This is a defector. You can see micro level. Because root cause we have to treat. Root cause. What are the root cause of SUI? There is a fibroblast, collagen, elastin damage. If you see the young skin and aged skin, you can see the fibroblast, collagen damage. That is the root cause of the factor of X factor of the SUI. So that is the reason we have to treat the root cause. So these are basic maturation cycles, how to attack nerves and internal and external sphincters, and with causes. If you see this stress urinary content, the bladder muscles and the sphincters are damaged and become weak. If you stand, there is, you see, this is a rest position. The actual position of this bladder should be here. Actual position here, but now it is here. Now it is here. That's why once you cough or sneeze laugh, already this bladder neck is goes into the urethra. Will hypermobility of urethra will cause the urine leak. This is the pathophysiology of the SUI. Okay. So now let me, this is the pathology you have covered now. Now we'll go for how to diagnosis, how to diagnostic approach, because this is very, very clinically, you have to go through the patient, because patient always, female patient are shy, unspoken. So be clearly taking history is very, very important. So patient approach diagnosis very important. Interacting patient very, very good in manner. Examination patient, detailed evaluation, option you have to see. Interacting patient, take lot of time. You counsel the patient, take the history, what actually she is suffering. Okay, so you have to see the, you ask in history, duration, severity, how is this affected, any mixed types of symptoms are there, comorbidity, diabetes, obesity. You have to take all the time of history. Mode of deliveries also you have seen now. You have to take all the history. Okay. So there are other examination. The clinically we have Boney's Marshall test, tube test, but nowadays not required. It is not also consideration this test. So mainly we do a coughing test. Just I am showing that only intra-abdominal pressure, how it increase, how the urine. So this type of flushing will be there. So I want to highlight is only cough test. So these are the already not required. Only there is a cough stress test. Universal cough stress set, very, very important patient to diagnose the incontinence. So a bladder full is required. How much bladder full required? At least bladder full sensation will get 200 to 400 ml of bladder urine in there. So how do you do it? Ask a patient, drink it, and once he's get the sensation of urination, then only you have to do the test. That is the best time to do test with the standing. Okay, so this is a very, very important. And so this is a test, and then the uroflowmetry, PAT test, cystoscopy, urodynamic doesn't require for all cases, but urodynamic cystoscopy require a specific cases, severity cases where you are planning to operate. Those cases it require, right? Because urodynamic nothing but it is called ECG of the urinary bladder. You do heart ECG like same. So multi-channel video monitoring the urodynamics are there. You can plan it, you can do it, you study how this urodynamic you do. With this, you can prove that what are the causes, like it is genuine stress urinary incontinence, or it is associated with any neurological problem, or associated the origin incontinence. So before your specific plan, you do the urodynamics and the diagnosis clarify associated with prolapse, any prior surgery, neurological factors are there. You can clarify in the urodynamics. Okay. So these are the things for a diagnostic approach. Once you diagnose a stress urinary incontinence, then you can grading it mild to moderate, moderate to severe. So now we diagnose mild to moderate cases. So mild to moderate cases, we do non-surgical. One is a lifestyle modification, rehabilitation, bladder diary, and the pelvic floor training, what already explained by the Azar, and the other devices. Like we use energy to strengthen the urethra. We use the laser, HIFEM, and PRP. For surgical, and there is a laparoscopic birth scalpel suspension, midurethral sinks for severe cases. So now we are dealing with only mild to moderate non-surgical. So even non-surgical medical management comes. The medical management is not much play in this role. Only duloxetine, serotonin non-epinephrine, duloxetine is only medicine. It is working in proven evidence that it is working in the mild to moderate cases. So weight reduction and bladder training, you can just follow this, the first line of management as nice guidelines, or International Continence Society, they advise first line of management. Even GSM, genitourinary menopause syndrome, you can use hormonal replacement therapies also local as well as this. So these are the medical therapy. Coming to the other therapies like physiotherapies, physical therapy. Here, what the main cause of the SUI, mild to moderate, you're thinking is the urethral tone, bladder tone is decreased, muscle disintegration. So this, again, you have to develop the tone. So this can be done by the patient own. Patient herself can do some exercises. So bladder training as well as Kegel exercise. Okay, Kegel exercise, they have a physiotherapy, we can do the Kegel exercise. You know the 6 types of Kegel exercise. It is voluntary contraction of the external urethra and bladder, abdominal muscles also, and the perineal body. So once you are doing Kegel exercise, still you have a now discussion here. You can advise the patient, but all the patient can able to do this. And I have a doubt that the exercise is voluntary here. Your contraction and releasing voluntary, but already explained internal sphincter, it is involuntary now supply. So this is a smooth muscle involuntary sphincter. So there you cannot do the involuntary of internal sphincter muscle. You try to understand it. Give the external as well as the perineal body, pelvic floor tightening, but not the internal bladder. For that, we have another energy. This is the biostimulation, biofeedback. This is only for sensor. In that, we have a electrical stimulation intravaginal. So this will have this electric stimulation that will stimulation will cause muscle contraction, even the smooth muscle also. See, this is a intravaginal vibratory system. You can use this, and you can go for this. Very, very economical one. But there are HIFEM pelvic muscle stimulator, electromagnetic stimulation, high focus, high intensity focus electromagnetic waves. If you give in the perineal body, definitely the muscle tone, muscle supra-muscle contraction. Supra-muscle contraction for only a minute 10,000 times. So there will be improving the muscle tone as well as internal and external perineal body. This is the evidence-based. This one chair we call. There are a lot of companies manufacturing the HIFEM chair. It is have a non-invasive, no complication. Just you can just go use and just sitting like with all clothes also just sitting. This waves will pass and will cause muscle contraction. Just model, I will show you animation model. Patient is simply on chair and you can watch the TV for half an hour. This is a 3 to 6 session is required, and you can improve the mild to moderate cases. You see now the before how the pelvic perineal body muscle thickness, and the after also you can see now the increasing the perineal body muscle thickness. It is give a supramaximal contraction. This is a FDA approval equipment. You can start in your clinic. You can convince patient, and you can mild to moderate cases. And not only the mild to moderate cases, even post-delivery, post-cesarean, you can do rehabilitation, bladder training, also even muscle exercise. You can combine with that. So these are the things for non-invasive medical as well as physiotherapy. So what are the severe cases or other cases when this not responding? Then what is alternate? Alternate we do is only surgical management. There is a gold standard midurethral sinks or birch laparoscopic colposcopy suspension. But these are the gold standard. But this require very expected. So the learning curve is more, expectation and require experience, require very meticulously how to do it. So here the stress urinary incontinence severe cases and would not affected by this mild to moderate therapy like a PRP, what you call earlier explained by physiotherapy and medical. You can go for the midurethral sinks and the birch colpo suspension. Okay, right? So here we want to discuss here is these are the gold standard methods, but here is the problem is here. Some doctors explain it's a gold standard, but some other are controversies. If you see this video, the International Incontinence Society, Azhar, your voice is this video voice is coming.
No, sir, it is not coming.
It's not coming. Okay. Melissa is asking one question for Tarkan. He is a professor in urology. There is a gold standard treatment for SUI, stress urinary incontinence. He said no. There is no gold standard till now treatment for SUI. Such a modern era, still gold standard treatment is not available for SUI. We have to think alternates. So when you are doing birch colpo suspension or TVT tape, but intraoperative, there is no complication, but perioperative, postoperative will have a lot of complication for TVT tape. Bladder injury, migration, rejections, and the pain. If you see this video, one of the TVT tape, TVT tape now is got rejection. There is a fistula formation. So we are removing the TV tapes. It is migrated into the bladder. Now you see this. So transvaginally we are removing. And next case, another TVT tape migrated into the bladder. The cystoscopic, you can see the mesh inside tape. Now laparoscopic, we are removing this and we are repairing the bladder. If you see this another case rejection, this is a intestinal migrate into bowels and bladder. TVT tapes, still their complications are there, still they are cutting gold standard. Now is confusion. You understand? So these are the done by the experienced doctors, gold medalist doctor, but who has to get this blame? Still it is confusion. So what is the gold standard means? What is the benchmark? A surgery, it can be reproducible. A surgery can be replicable. A surgery have a less complications, and surgery cannot be a disaster. This is called a gold standard. But do you think there are a lot of complication and TVT tape, midurethral sinks are gold standard or birch laparoscopy is gold standard? Now is confusion. We are in the crossroad. How to do it? This. Now thinking of that. So main actual pathology there is a urethral support lossing, restoring this urethral support. So the muscle restoration is only for by the PVT tape. Other alternate by the we had already explained Dr. Kaushik by the stem cells and the PRP lasers. Also, we can restore mild to moderate, especially cases you can restore the urethra integrity. Mild to moderate cases, SUI also can be managed by the alternate way. What are the alternate way? By the non-surgical method. One is the laser, the PRP, stem cells. Okay, these are the alternate method. You have seen the molecular pathology of the urethra, what they are, collagen, elastin fiber damage. You have to rectify that. So we are thinking, so now we are alternate for this. So there is a alternate thing, say energy-based device, go for the SUI. Because this slide already explains 70% of SUI are mild to moderate. Leave it 26% of severe cases, leave it. Only 70% we are concentrating mild to moderate cases. Those cases can be managed by the non-surgical method. Vaginal regeneration by lasers, radio frequency, you can use HIFU, thermal energies. Okay, this one or PRP. So let me start now. Is a mainly thing is a laser. Okay, so lasers are energy-based device. We have a two types of laser. One is ablative laser. One is another is non-ablative laser. Ablative is CO2, fractional. Non-ablative is diode and erbium. Right? Laser already he explained the wavelength and how they action, reflection, absorption, scattering, transmission, energy levels. So already he is explained. So I'm going to for CO2 lasers. Laser I already told ablative and non-ablative. Ablative lasers are CO2 lasers. CO2 is a fractional laser with carbon dioxide. They use carbon dioxide gas and the energy they deliver. So how it works? CO2 laser, we have a fiber inside, we have a glass tube, vaginal glass tube. Laser energy delivery through the vaginal tissue through the diffractive optical element. There is a glass tube. And the diffractive lets it beam of 81 microscopic pixel 9 into 9 form in 1 centimeter. So this is the things you can see there. So we'll show you animation video how it acts. So this laser energy will have a micropore inside. This energy will goes in the epithelium of the mucosa and will cause micro injury, deep thermal effect, and micro injury will cause collagen production, collagen remodeling, and with ablations. You see the CO2 fractional laser, how all this we are going into the epithelium of the vagina. So this is the animation video. We have a CO2 laser. This is, you can see now, this is the vaginal probe. It's rotating and it's giving continuous 360 degrees. All the energy, micro 360 degrees, it releases inside. Okay, so this is the CO2 laser. This is we have a glass inside probe. You can use this sterilized glass and you can use. It is easily usable. It is clinically proven. There is a collagen remodulation. This is another animation video you can see now. CO2 fractional laser. This is a optical tube put inside. The CO2 probe of laser probe is go inside, and from the between the cervicovaginal junction, you give the this is laser energy. You can see how the micropores action is working. So these are multiple micropores will cause micro injury, and it gives the collagen remodulation and thickening in the vaginal wall. So vaginal tightening and even collagen production, it works. But the problem of CO2 laser, it is a microablative, and you can see now these pictures, micropores. If you see in the colposcopy, you can see the micropores. Because of open micropores, will get infection. It tissue damage, more damage, and even sometimes nose damage, dysmenorrhea there, and sometimes more energy release, carbonization. After this, will have a healing process, alter the collagen, but it causes fibrosis. That is the reason ablative therapy, ablative micro CO2 laser, FDA warned in 2018, it is using in the vagina. So be careful to using the CO2 laser. So even 2018, FDA warned because of rethinking of techno-vagina. They are using when you are because of fibrosis, vaginal stenosis, and the dysmenorrhea, even the all infections. That is the reason, again, we are thinking of alternate this. We are going for alternate. You see this CO2 fractional laser, and this is a diode laser. Now you have to already explained by this, by the Azar, because CO2 fractional laser is a superficial, will have a micropore action, ablative. It is non-ablative. So if you have we have a comparative study of erbium and diode laser to CO2 laser, they get conclusion. They got conclusion of the in vaginal regeneration, vaginal tightening, SUI, the diode laser better working than CO2 laser. So then we plan now we are working in the only diode laser in vaginal regeneration, vaginal tightening, and SUI. Now that we are coming to the diode laser. So that how the diode laser works. Diode is a non-ablative. It is smooth muscle effect on the smooth muscle and the vaginal epithelium. So deeper penetration. Like this is a laser is a light energy. Laser is a light energy. Low laser energy therapy, it goes into the deeper structure of the epithelium and the epidermis, linea propria, and the muscle also. Now this will cause a micro absorption. It is not micro ablation. It is just absorption. It will cause new remodeling synthesis of new collagen fiber. A very, very smooth action. So if you see this, when the releasing temperature, all these are thermal effect. Once it absorbs in the tissue, it increases the temperature of 60 to 63 centigrade. Thermal effect will cause the micro light absorption, light energy will have a new collagen synthesis. The energy calculation, it's depending on a patient and to what clinical indication. We always go for low energy, long term. So if you see this, when the time when increase, this will have a spreading, when the energy spreading transfer. If you use the energy, the watts, it goes a deeper penetration. So less watts, more time will have a good interaction, this one. So how the laser works in the vagina? I already mechanical diode laser, photothermal interaction, thermomechanical interaction, and the growth of new collagen fibers. This is mechanism of action. So this collagen, what we thermal effect produce in the vagina are permanent? No, that is a very drawback. This is the not permanent long-term effect we have. They have phase 1, phase 2, phase 3, phase 5. It collagen produce, it remain, and collagen degrade. Again, it is gradually decrease the collagen firmness highest time. Because it is a, I can say that it is not permanent. It is long term, but it's not permanent. Okay, that is the reason non-surgical therapies, you have a multiple session required. Again, maintenance dose also required. You got it. It is not a permanent, which was one sitting, multiple sitting required, and the maintenance dose also required. So accessories, the fibers. The laser, if you have a two action, one is non-contact ablation, one is a contact ablation. So already explained how it forms a collagen. When the contraction of inner lining of the vagina, vaginal epithelium, increase the production of collagen, formation, development of elastic tissue, elastogenesis, and new vessel, new angiogenesis, new blood vessel, new collagen formation, increase the cell synthesis production. If you see this non-contact mechanism, laser, in the vaginal epithelium, so these lasers will having gone inside, absorbing inside, and it is non-contact. The same laser, if you see here, in hysteroscopy, when you contact like a septum, how it is cutting. So when the temperature, when the watts increases, when you contact it have a different action. If it is non-ablative, non-contact, if you see here, so if you see this, so only this light energy absorbed in the vaginal epithelium and of muscle will have a new collagen formation here. Here is a cutting ablations here. So these are different mode of action in different things. Now we are talking about laser vaginal regeneration. SUI or combination therapy we do. Stress urinary incontinence. We do diode laser, 4 sittings, and we have a protocol. We combined with a PRP. You got it? We have a combined, we have program develop our own. So this is a laser equipment. It is compact. It is plug and play. We'll have a fiber, vaginal laser fiber. We have a vaginal, this one optical uh, tube. You can pass in the, this is a reusable. You can just sterilize it. You can use it. And you can, this laser energy you can insert into the vagina. So laser vaginal tightening, I told 4 session, we use 5 watt to 6 watts with 600 milliseconds, and we'll give a laser energy for this procedure. So laser energy, what are the evidence? What are the tests you confirm it is action or it is useful? So if you see the histopathologically, after laser 4 sittings, now you can see the another slide here. This slide you can compare 2 slides. There is a vascular bursts inside. There is a new angiogenesis, new nerves, new vascular and new collagen cells are formation. You can see now. That means laser is working in the vaginal tightening. It is incontinence or whatever you see. So laser epithelium is affecting. No, it is improving. The quality, thickness improving. So another slide, you can see this same. We have a more fibroblast, cellular epithelium, and you can see now the improvement of the epithelium of vagina by lasers. This is the one evidence. Okay. So that is the reason why we are preferring the mild to moderate vaginal regeneration, SUI, by lasers within 1470. Increase collagen, increase muscle tone, improve sensation, enhance organism, reduce vaginal dryness, lubrication increase, full outpatient, it is only outpatient. It's very painless, non-invasive procedure, no side effect, no anesthesia is required. It is only OPD procedure. You can do your OPD and you can improve the patients and you can see the happy patients also. So these are levels of evidence based. It's a level 4 and the D recommendations in the data. This is a laser concern. But there are over these diode lasers or FDA approved. We have a few studies, heterogeneity, but RCT has not done. But because of all lasers you can use in a human bodies, there's no thing. Somebody is telling there is no FDA approval for diode laser. Definitely FDA approval for the diode laser. Only diode, only CO2 laser FDA is warned before because of complication they found. But diode laser, there is no complication. FDA given permission, FDA approval is there. So some of the animation video, how you do, some videos are surgical videos, how you do the laser in stress urinary incontinence. So this is a laser probe you are seeing. First is we have a 3 brackets inside that probe plastic cover is there. So it releases a 3-cone type. So it will control the infection. Laser also antimicrobial. Heat can kill the bacteria, virus also. So first we prepare the patient with the infection control, giving the energy of the 5 watts with the 50 joules for 3 to 4 passes, and we'll give a infection control. Then we do a only anterior side. We give a more energy. With the anterior side, we'll give a more energy of the 60 watts. You see the anterior side, we'll give a 60 watts at the urethral side, anterior vaginal wall and urethra, suburethra. So there vaginal wall of the have a collagen production, vaginal tightening, and even you can improve the urethral stone. So that can improve the SUIs, mild to moderate. We have a protocol 4 to 5 sittings, and we have a maintenance also. See this, we are giving only anterior to like a 2 o'clock to 10 o'clock. With this, we are giving energy of 60 joules per centimeters. We are giving a 3 passes. So this will give a more thermal energy in the anterior vaginal wall and suburethral level. So next is this is the thermal energy laser in the vaginal regeneration, vaginal tightening, vaginal maintenance of assessed urinary incontinence. Now another option, we have a regenerative medicine, which was excellently explained by the Dr. Kaushik. So what are the things to combine this procedure will have a effectiveness the treatment, enhancing a result of this one, non-surgical. So we have another, this is a regenerative medicine. We have a platelet-rich plasma. This you prepare from your blood, patient own blood, you can prepare. And the preparation procedure, we have a, I will explain. What is a PRP? Platelet-rich plasma will have a cocktail of growth factor. A lot of growth factors are there. This growth factor, uh, and it can, if you include calcium, will have a more actions. So growth factor will have a increase the damage, whatever damage that heals. The healing process of the damage area and wound area will be action. Already we'll explain the types of PRP. We have a pure PRP, we have a leukocyte PRP, which was explained the Kaushik, and the pure platelet rich in fibrin also. There is a leukocyte platelet rich fibrin. These are the products like of a PRP. So this, depending on the wherever you're using clinical condition, can produce generate the PRP from the patient own blood. So if you take the 50 ml blood, you get the 4 to 5 ml of. So 1 is to 10 ml. 1 ml PRP can prepare 10 ml, right? So 50 ml we have 5 ml. So our concentrate SUI, we take 50 ml blood, we'll concentrate spin 2 times, and we can get the concentrate rich plasma here. We'll get 5 ml, right? This is the process of generation. Now the coming to the action, mechanism of action. How PRP affecting the degenerative or damaged area. So growth factor promote wound healing by resolution, chemotaxis, cell regeneration, cell proliferation, migration, extracellular matrix synthesis, remodeling, angiogenesis, epithelialization. So these micro wounds, already I told the molecular level, collagen, elastin fiber, that damaged fiber heals by the PRP. Then the urethral tone, perineal body tone, muscle tone will improve by the PRP. So what are indication? You know, already indications are different, like hair loss, knee osteoarthritis, lot of indications. So pre and post check doesn't require because FDA doesn't require because we are taking own patient, own blood and own giving this, doesn't require DCCA permissions also. Contraindication, all these are cancer, lactation. So this PRP we are giving in gynecology for other indication also, vaginal regeneration, vaginal tightening, vaginal lubrications, sexual enhancement, or other of in this especially. So in SUI, there is a O shot, P shot, G spot. We have all this one, especially in the SUI. Especially mild to moderate SUIs. Now the laser is over, then the second is the PRP. You see this PRP, this one PRP, tissue engineers, this restoration of urethral support, mild to moderate cases. You understand? Mild to moderate cases, we are giving a PRP in different techniques. I will explain. And okay, before that, I will also explain the vaginal regeneration. How do you do O shots, P shot, G spot? P shot is penile. G, you can see you're taking the plasma PRP. We are injecting the G spot. G spot, it's a below paraurethral below 1 centimeter, you can feel the pubic bone, and there you can inject the G spot for vaginal regeneration, for enhancing the orgasm. And introitus, all introitus, you can give multiple 4 ml of, you can take, this is called O shot. For this, all these are vaginal regeneration. You can give multiple injection around the introitus. Okay. So now the SUI, we're talking about SUI, mild to moderate cases, how to do PRP. You know the process of PRP, and we centrifuge, we plan the PRP. So there are 2 studies, they given the advice, and they published, they have given article also. PRP, you can give suburethral region. One, you can see the below 1 centimeter, center 2 ml, lateral 1.5 ml, 1.5 ml. Around, if you take 50 ml, 5 ml of PRP, you can give a suburethral. One thing. And the PRP also, you can give the ISD of internal sphincter of the urethra. You can inject through the cystoscopic guided. Okay, you can give a like a 5 spots, like a 2, 5, 6, 7, or 9. This you can plan the 5 spots, and you can give 1 ml, 5 spot, 5 ml. This is intrasphincteric. This is suburethral. This is periurethral, intraurethral at intrasphincteric area. Okay, so but this is cystoscopic. So now we'll come to the periurethral injection. How you do? So in transsphincteric, so you can inject through the cystoscopic guided, like a bulking agent. What you inject, you can inject in the this smooth muscle of internal sphincter. Okay, 5 spots you can inject it. You can have a 4 sittings apart a month, monthly, 4 months. We can inject, and the study also show effectiveness, efficacy, specificity, no complication, but there are improvement. So this is one of the video we are doing. We have it. Azhar, you are getting voice of this video?
No, sir.
Yeah. No? Okay. So this is we are doing the transurethral intrasphincteric PRP injection. We are using cystoscopy injections, needles are there. That is a Chiba needle, 5 French needle. We have a 23 gauge, like a spinal, 23 gauge thickness. So we are taking from a cystoscopic transurethral. We are planning the 5 spots of the internal sphincter, and we are injecting 1 ml. So if we do 4 sittings like that, we have seen the results. We have seen the happy patients. You can see this, how this is, I'm just showing the attachment, how you do it, how to assemble this one, cystoscopic. If you have this, you can, I'm collecting the PRP from the tubes. This 5 ml of PRP from the, you can see the cystoscopic guided. See, this is the internal sphincter. You can see how the inside, you can see damage, looseness, and the flabby. So it is, see the movements, hypermobility. So this sphincter, internal sphincter, 5 spots you can plan, and 5 sides. You can 1 ml penetration, and you can give it. We have a special cystoscopic needles, 5 French needles, 23 gauge needle, Chiba needle. You can inject inside. So this is Chiba needle passing through cystoscope. So now this you can see now. Yeah, I'm inside. This needle is going inside. You see now? It is already injecting the internal sphincter of this PRP. And the future, we can also do it exosomes and PRP fibrin and LPRP also. We'll show you the results maybe better than this, what we are doing now. So got it now? So this is the transurethral intrasphincteric PRP injections of a SUI, mild to moderate cases. So next method is we do is because of mild cases. For mild cases, we use just simple injection in the anterior vaginal wall. We have a suburethral space like below 1 centimeter. Can inject 3 spots, 2 ml, 1.5 ml. So you see now this PRP which are collected PRP, we are injecting to anterior vaginal wall at below 1 centimeter of suburethral space, just for suburethral space 1 centimeter, 1 to 1 centimeter deep, and you can inject it. Three spots. So this also we have seen the mild cases are improvement with Kegel and we are adding with PRP. So we are adding combination of therapy. So we are getting the best results in the mild cases. So this is another, this is studies which have shown the urethral sphincter injection, platelet-rich plasma, urinary incontinence, intrasphincter deficiency. We have a thesis studies inclusive criteria and the exclusive criteria and the result wise and the evidence based visual analog score, pain and the improvement. We have published this type of results are 85% improved. We have a complication, urinary infection, delayed hematuria, but most of cases 1 or 2%. These are the can manage with medical antibiotics. So the conclusion is urethral PRP injection is a safe, effective treatment for refractory ISD for SUI. 83% improvement and 45 to 8% success rate. With if you do stem cells, if you go for LPRP and exosome combination, then we'll have success rate will increase. Definitely the committee people, international doctors, the professor, they should go for this and do some research, experiments, and to alternate for the avoid the complication in future like with the TVT tapes. This is a summary. So what is our things? This is a stress urinary incontinence, mild to moderate cases. We can do non-surgically with laser energy, with PRP stem cells, and we'll get a happy patient, happy results. So this is the thing we want to highlight today. Then what is the future? Future already explained the stem cells, other things by the Kaushik. I think there is this one will be people are other countries they are doing with cell therapy from the muscle cell, they culture it, making it the stem cells of muscle cells, muscle tomes, and they are injecting to the affected area and to have a cell therapies. So these are things. What is the carry home message? Now you cannot confusion now. You should carry some message to home. Here the stress urinary content, mild to moderate, to restoration of urethral support, mild to moderate, you have a Kegel exercise, HIFEM chairs, and you have a laser PRP, we have a stem cells therapy also. To avoid all this surgical complication, mild to moderate cases, then you can plan, you can do with this modality with a minimal complication with a maximum benefit, maximum advantage, less disadvantage. This is a thank you. This is our thing I want to explain. If you have a thing, I can have one or two things. There is another energy, radio frequency, There are experimental research transurethral. This radio frequency can do release the energy in the intrasphincters, and they will cause the micro injuries, minimal injury, will have a remodulation treatment. This is the one thing still it is going experimental. FDA so approved. In other countries, transurethral radio frequency collagen denaturation, they are using this one. Another thing I want to explain, this is bulk agents. Like a mild to moderate cases, we have a cystoscopic intrasphincter. We inject the bulk agent to avoid the defect of the internal sphincter. But in India, it is very available to very problem, and in other Western countries they are doing, but it has a complications. Our results are not optimum. So because of migration, foreign body reaction, it's a bovine collagen material, like a bulk made other things. So it is not, I think, in India. So, but future is the regenerative medicine. Anyone can Azhar,
Yes, sir.
Azhar.
Yes, sir. Yes, sir.
See the woman. Can you say her name? Anyone can say her name. This is a question for any audience. You just recognize her. No, Azhar.
No, sir. No, sir.
You can't recognize. Now you can recognize. Now you recognize.
Yeah, everybody can recognize now.
So what the problem here? It is the aging process. So aging the main problem, and the aging we cannot avoid it, but we can postpone it by the regenerative medicine. Try to understand.
True, sir. True, sir. Yes.
Yeah, it is not complete postpone, just like postpone minimum,
Yes.
like a gap of this minimum. You
True,
can
sir.
postpone by the region, PRP or stem cells and things. If you see this, if you don't think bad, but it touched my heart. Regenerative medicine, if you see this couple, after 70, 60 years, they want child. So by showing the dance, by taking the stem cells, regenerative medicine, ultimately they're blessed with one child. You see now, you know, ultimately they're blessed with child. There is a future of regenerative medicine. Definitely the play a role, but need more research, need more experimentals, and more standardization. That is the reason most of the scientists and the biotechnologists and the doctors, community people will come forward to do something research to avoid this complication, avoid all these problems in this whatever stress urinary contents of old age people. They have to give a good quality of life. So these are things. Thank you, Azhar and other doctors, and thank you me and this opportunity. Any questions you can ask.
Sir, good evening. I am Dr. Sandhya, gynecologist, Warangal.
Madam, good evening.
Sir.
Madam, how are you, madam?
Sir, took a lot of time, but it's very nice. And even from the beginning, I'm there, sir.
Okay. Yes, madam. I've seen the madam. You are in the national gynecologist and famous in Warangal. Like you people come forward to do like a PRP stem cell for stress urinary contents. You have been telling me a lot of cases are suffering unspoken in Warangal people. Lot of patients.
Almost every gynec patient, apart from antenatal pregnant, even after delivery patients of antenatal, and all gynec patients, if you put a question, leading question, patients they won't tell themselves. If you ask, is there any problem with urinary incontinence? Is there any leak from cough or any weightlifting or any if you ask leading questions, definitely they will come forward. Otherwise, they won't tell.
Yeah. Yes, ma'am. Then recently AIMS also has been conducted a survey. 1 in 3 women, more than that also, we have a problems unspoken suffering, silent suffering in the society, community. So, madam, we can plan in the future with LPRP, stem cells in your hospital. We'll conduct workshop. We'll get the Kaushik, Dr. Kaushik, even other people, laser combination with the PRP in future.
And also we need more of evidence, sir, because if you tell to the patient,
Yeah. That is the main problem, because people are Indian
acceptancy.
mentality. Indian mentality they are all one shot experience. One shot
You
they
will give
want.
guarantee,
One shot.
guarantee.
Yeah.
They will ask only question.
Everything
Guarantee.
question. But there are people now changing the scenario, also changing, educating. Lot of medical peoples are there. They are coming forward. So there, if you take the laparoscopic example earlier 20 years back, convincing patient very difficult. Now the
Yes.
patient themselves, they are coming for
They're
laparoscopy.
asking, for lab.
Yeah, that will be changed the scenario, but we cannot exception, not example. And definitely we can do some workshop. We can highlight this and we can enlighten this, eye-opening to the even medical doctors. Most of
Yes.
doctors are not aware of this regenerative
We
medicine
should
in the
create
gynecology.
awareness among gynecologists, sir.
Yes,
And
yes.
because gynecologists are the doctors, at least they
That,
can tell to the patients.
that is the reason we want to choose Master Blaster, your Sachin Tendulkar in Telangana. We want to choose you.
Sir.
Hmm? Yes,
And
definitely, madam.
urinary syndrome of menopause, GSM.
Yes, sir.
Genital
Yes,
urinary
yes.
syndrome of menopause also is increasing nowadays because.
Yeah. Things like a sedentary life and what you call a psychological stressful life. There is a
Yes.
hormonal imbalance always there. You can go for this replacement hormonal therapy, adding laser and PRP. Will have a GSM very, very good result in the menopause.
Sir, thank you.
Yes,
Thank you.
madam.
Thank you.
Thank you, ma'am.
Thank you.
Thank you very much, sir.
Is there any?
Yeah. You ask anybody has having questions, sir, so that we can.
Because this is a vast subject, most of people are confused. Maybe they carry home message. They can now come up with questioning or. So what the reason here to conduct a workshop is we'll prepare you critical wise. For we'll come to your hospital. If you pull up the cases, we'll do your hospital only. We'll come and our team will come. We'll train you. We'll give like a presentation. We'll give evidence. We'll give a hands-on training in your hospital. This is the what we are doing in across the India, even across global other countries also. We have been conducting workshop like in microwave uterus, uterine pathology, fibroids, and adenomas, endometriosis. We're doing micro workshops also. In future, we are doing SUI workshop with laser and the PRP and the stem cells. So we are collaborating with Diploma, Dr. Kaushik, and our team will come and train you.
Yes, sir. Anyone having any queries, please ask Dr. Shankar sir or Dr. Kaushik sir so that they can be.
First, they advise you unmute themselves, speak something. Otherwise, they don't know it because.
Yeah. Please unmute yourself while asking the questions. If you have any queries or questions, you can ask related to stem cells or stress incontinence or anything related to non-surgical procedure for management of SUI. So it is very clear that everybody has understood the topic clearly. Thank you, Shankar sir, for doing the best. Thank you, Kaushik, Dr. Kaushik sir,
Thank you.
being a part of
Thank you.
the team.
Thank you, sir.
We will be conducting these kind of programs again and again, at least
Yes,
once
yes.
in a month on a different
Yeah.
topic, so that we can reach out the maximum doctors and we can share the knowledge with them.
Thank you.
Thank you, sir.
sir.
Thank you. Thank you, sir. Thank you.